Good morning, and congratulations. Who's actually graduating today? Yeah, very exciting. So yeah, I'm Sukhi. I am here to sort of give you an idea of what life after residency can look like. I didn't anticipate the path that I'm on. I knew that I wanted to work in social determinants, but I feel really fortunate as to what has happened in my career thus far in less than 3 years. And I wanted to give you a sense of what's possible. I apologize for the EMIMs. You saw a good amount of this in our dual training lecture. But it's more or less to give you a sense of the opportunities for advocacy and the opportunities that we have as clinicians to really inform our practice with social determinants of health. So, social emergency medicine is the new buzzword, right? Like, everyone's sort of talking about it. There's a section at ACEP. There's, SAM also has one. A lot of stuff is driven out of the Levitt Center in California, looking at social determinants. They've been doing it for a few years. But in all honesty, EM has staked a claim in wanting to look at social determinants, but none of this is new, right? Our profession as clinicians has a long history of advocacy. It has a long history of oppression and sort of bigotry as well, but there was a initial ethos to do good, and that's been a part of being a physician for many years. The use of social with the word medicine is not new either. There was a book reviewed in 1954 in JAMA concerning social medicine, and since that time, there's been a plethora of sort of publications from multiple organizations. The one that most people are probably most familiar with is Unequal Treatment, looking at specifically race and ethnicity and how that affects health outcomes. The Solid Facts is out of Europe, looking at just social determinants of health. This one, I think, was out of in 2003. And the Social Medicine Reader, actually, the most recent edition just came out in 2019, and is out of a collective from UNC that's very multidisciplinary. And I actually became familiar with the reader when I was in grad school in sociology, and is also really an excellent reader looking at how social factors really impact health. So what I wanted to do is give you a sense of what it means to practice social medicine in sort of a education realm, and what the opportunities could be there for you, and what it looks like to do hospital-based interventions. And the one that I specifically am involved in at my institution is concerning medication-assisted treatment of opioid use disorder, and then what community-based initiatives look like on a grander scale. And the larger piece that I'll be talking about here is our Better Housing Program, where we have been taking individuals from the emergency department and housing them, and seeing what happens when you do that in terms of hospital utilization and healthcare costs. So, social determinants of health, right? It's sort of this key term that gets used a lot, but what does it actually mean? So this schematic was actually made from a consulting group called Drawing Change, but the group that they looked at and asked was a group of First Nations individuals in British Columbia. And they asked them, what do you think impacts your health? And the things that what I like about this, it actually broadens what we sort of think about in terms of transportation security, food insecurity, things like self-determination, things like racism is one that's common, but also things like your actual control of your resources. Colonialism is a big one. What does the impact of structural violence through generations do to a community and their health outcomes? So this is what you can sort of generate when you ask a community what it is that they think impacts their health. But what does it actually look like when you try and conceptualize it on a population level? So this is one of the most common schematics that is out there. That's the basis of a good amount of work that's even like out of the social determinants of stuff, social determinants of health in the CDC. But this is the Dahlgren-Whitehead rainbow model that was generated in 1991. And basically what they looked at was, if we understand that our environment impacts our health, what does it actually look like? There are flaws in this because it doesn't actually look at the intersectionality of all of these areas, but they put the individual at the center. You can't change your age, you can't change your sex or your genetics. But what you do beyond that very much so impacts you. What your impact on your environment is in terms of your behaviors, and what your actual location in life does, and how that ends up really determining many things when it comes to health, especially your comorbidities, your life expectancy, and basically your overall health status. So, if we understand that that's where social determinants can impact our overall health, what impact does it actually make in an aggregate level? This is out of the Democracy Collaborative that basically asked, can hospitals heal communities? That's the document this is out of. And they wanted to kind of depict how much of what we do in the walls of a hospital actually impacts care. And it's not very much. The thing to get out of this is, really, if we were to look at quality of care and just even access to care, what we do within the walls of our institutions is like 20%. What we actually experience as individuals in communities and in our society is far more impactful. And it's not news, right? We know that sanitation and infrastructure is what actually improve life expectancy globally and locally. And it's time for us to actually look at those things and operationalize them in the practice of medicine as well. So one of the sort of recent books that tackles this, has anyone heard of David Ansel? There you go. Oh, Rush, that's why. So he is, he trained at Cook County, and he wrote another book about his time at Cook County. But this, I think, came out either last year or this year, because I've heard him speak many times about it. But basically, what David Ansel looks at in the death gap is life expectancy and ties it to a lot of social determinants, but location ends up being a common theme in the book. And so what he has sort of wanted to relay is we have like a clear kind of ability to understand a map like this. This is sort of looking at, I think, CIA World Factbook data. I think Wikipedia is where somebody made this, but like it actually, I checked the data. It actually is looking at what was in there, what was in the document. But we know that if you're born in Canada, if you're born in the U.S., you live much longer, and your likelihood of living to greater than 75 is much greater than if you were born in South Sudan. And we sort of are able to appreciate that by realizing the lack of resources. We call sort of the continent of Africa a developing nation, but it's different countries, and are able to sort of realize what it means on a global scale. But out of a lot of work that's been done through multiple funding sources, this is out of the Robert Johnson Foundation, but several larger institutes are doing this. They're mapping what life expectancy means in a city. So this is Chicago. And the United Center is basically where the Illinois Medical District is, and that's where I work. And it's somewhat staggering that if you are living in the area that, let me see if I can actually, does this work? Okay, never mind. So where it says 85 is basically, that's the community that I live in. It's like West Loop, the Loop in Chicago. You go less than 4 miles west, and it's 72. So just by virtue of being born in a different location in the city of Chicago, your life expectancy drops. West and south sides of Chicago are notoriously known as the areas where there's a lot of economic deprivation, there's a lot of racial segregation, and just lack of opportunity. But it's really stark in when you start to look at actual health outcomes, and how do we then sort of try and figure out what we can do to impact this, right? Because it's somewhat unacceptable for us to have an area in Chicago to have a life expectancy that's similar to countries in South America if we're thinking that we are sort of the beacon of development and having like an excellent sort of society. I say that being Canadian, I don't actually necessarily believe that of the United States, but that's sort of what we've sold. So how do you sort of differentiate this, right? Like, we know that our environment impacts health. We know that there are multiple factors when it comes to your physical location, racism, your gender, your ethnicity, your ability to secure housing, your ability to have food on the table, that impacts a whole bunch of your health outcome factors. But how do you then sort of try and tackle it? Because one of the things that we used to talk about when I was a resident here is just like, it becomes overwhelming. It's like people need a life transplant, but that doesn't actually work, right? We need to impact our communities, and we can, but we just need to figure out what it is that we need to do. So this is where I work, the University of Illinois Chicago. It's in the Illinois Medical District, which is a weird place. There are 4 hospitals within 2 miles apparently, but I feel like it's a mile because I walk past them every single day when I go to work. Cook County's there, Rush is there, Jesse Brown VA, and then the University of Illinois. You can see 2 of the hospitals in this picture. In the far behind the University of Illinois is the VA, and then Cook County is sort of the building that's kind of sorry. And so what the University of Illinois did, and this is a unique institution because we have 7 health colleges, so we have the opportunity to have multiple areas of expertise that can help us generate information. So we have 7 health colleges. We have nursing, dentistry, medicine, pharmacy, a school of public health, applied sciences, and social work. And so what happened, this was before my time, but I've used this document so much in my work, is a needs assessment was done of the community that we serve. And we needed to sort of look at what are the major neighborhoods that we are the major sort of healthcare provider for. The University of Illinois is a state institution, it's the state safety net hospital, so we do take all prisoners, and it's sort of downstate of Illinois, but like it's also very much so in a community that is sort of in the center of, or it has easy access to the south and west sides, which are some of the most economically deprived areas in Chicago. So they started looking at who is it that we actually serve, and why I use this slide is that it really sort of helps me see how segregated Chicago really is. So the blue and the sort of light teal colors are Black and Hispanic individuals, respectively. The lime green is white, and purple is Asian. And so the vast majority of the neighborhoods that we actually serve are really diverse, and they're all minority populations. But also, we have a great deal of economic deprivation in our catchment area. So, in addition to just doing demographics, you have to sort of look at what social determinants are people actually struggling with. So they started to look at the major ones that CMS, I think actually the funding came from that, so that's one of the reasons why these were the specific social determinants of health that they wanted to look at for the population served at UI Health. And so transportation needs are up there. Housing insecurity, employment and income insecurity is almost 90% of the patients that we serve. And then things like family and social support, utilities, food, interpersonal violence were also looked at as well. So now that we kind of have a sense and at least an idea of the specific things that our population struggles with, we had a point of departure to kind of see what is it that we can do to impact health. And so a good amount of the stuff that happens, that I'm going to talk about, predates me. I've gotten involved in a good amount of the work as well. But a testament to what we are doing at UI Health is really a function of what the department has been committed to for a long period of time. So when I started at UI Health, we had a faculty development retreat. It's such a weird thing to go to an institution and be like, this is what people do. And so basically, the institution, there was a huge overhaul. Most people don't leave state institutions, so we had a good amount of new attendees come in. And so they decided to sort of take a look as to what direction do we want to go in. And so social emergency medicine ended up being a big realization of, we've been looking at social determinants a lot as a department at the Department of Emergency Medicine at the University of Illinois. And how do we then sort of bring that to the community in an outward-facing sort of way? So obviously branding and marketing gets put into that, so that's why that thing sort of got made. But the other piece was actually realizing that the work that we've done has done a lot, has had a lot to do with community engagement. I'm going to talk about a couple of the things here, but this is what it means to practice social medicine. So C-Touched and Touch-DD are 2 federally funded studies that we're looking at what happens when we actually intervene on asymptomatic hypertension in marginalized communities. Do we actually see benefits in their cardiovascular risk scores over time? There's been multiple sort of areas of different attendings looking at other aspects like cardiac remodeling through ultrasound, if we start intervening at targeted blood pressure therapy early when patients aren't symptomatic. But the bigger one that is amazing, and I know other communities have done it, but Illinois Heart Rescue is a large sort of good example of what can happen. You don't necessarily have to. I didn't realize, but there's a lot of opportunities that you can get funding for that are not national sort of large organizations. And so I'm leading a grant from the Illinois Public Health Institute that's basically trying to bring MAT to our emergency department, which is being done across the country. Gilda Navrio's work is what's out of NIDA. Shout and ED Bridge are out of California, and Prescribe to Prevent has been out for a long period of time. And those are all SAMHSA and obviously NIDA funded sort of ways to help clinicians who are not well-versed in addiction to help patients in the absence of the sort of training that one gets as an addiction medicine physician. The opioid epidemic is not going to be sort of fixed by just one specialty, right? It's being felt by primary care. I'm a part of an opioid use disorder collaborative at the University of Chicago, and it's basically all primary care physicians just having no idea what they can do. And so the way that we will be able to sort of tackle this, especially in Chicago, is actually leveraging the expertise of people who have done this, but also the work of people that have already sort of shown efficacy in the protocols that they've developed to treat opioid use disorder, not with a toxicology background, not with necessarily addictions background, but they have those individuals for best practices, but applying those and actually implementing interventions and assistance for people that are seeking help, that are ready for it. So that's sort of one of the things that we've looked at from a hospital-based sort of initiative. The last thing I'm going to talk about is what social medicine can look like at an aggregate. And I presented this with Steve Brown, who was the director of the program at ACET this year for the Research Forum. So basically, the Better Health Through Housing program is a program that is a partnership between the University of Illinois and the Center for Housing and Health, which is a subsidiary of the AIDS Foundation in Chicago. And they are sort of a relay for the housing units that are in Chicago that are sort of through HUD, the Housing and Urban Development Agency. So the partnership basically was, what can we do to try and impact the overutilization of healthcare resources by those who are chronically homeless? If we start investing in providing housing, we're not actually paying for the housing units, we're paying for the actual supportive care that comes with it, so the case management and the agencies that are actually providing the supports for individuals to be in housing. But we are leveraging the housing that's available through the coordinated entry system that's in all cities that are sort of government funded housing for people who are chronically homeless or unstably housed, basically. So we got $250,000 of pilot funding, which allowed us to at least bring in 26 individuals. And then the housing units themselves were the ones that are available through the government. We were able to obtain a waiver, so we didn't have to go through the coordinated entry system because of this investment from the hospital. So the first round, we're actually starting the third round in July, but this was the first cohort. The first thing that we had to figure out was who's actually homeless. We think we know, right? But we don't actually document anything very well. So a big thing that we had to start with was figuring out who was actually chronically homeless who came to our emergency department. And in the first cohort, we were able to identify about 575, but that's ballooned now to at least, I think last count was 1,600. And then individuals were referred from the ED to a chronically homeless referral panel, which is where I got involved. And we sort of adjudicate what it is that, what are the barriers to the individuals that are coming in? Do we think that they would succeed in permanent supportive housing? And do we think that we can get them there? So it's sort of a way to kind of avoid bias, but we all have our own sort of perspectives, but bring multiple perspectives from agencies, community agencies, and multidisciplinary individuals from our hospital to figure out who could actually thrive in a program where we try to house someone. We would then find the individuals through Heartland Alliance. They have an outreach worker because all these patients were still homeless, and then engage them to try and put them into permanent supportive housing. So what did we find? We know that homelessness is a dangerous health condition, right? Being chronically homeless, on average, will take 27 years off your life. And we didn't realize how many people were going to die in the cohort that we actually initially started with. So 31% actually have died. One of the only woman that's left remaining in housing, from what I understand, I think she's in hospice. So it's not going to be much longer. But the other piece that we sort of came to realize was we needed a better way to figure out who was going to actually succeed in permanent supportive housing. We had discharged a lot of individuals because of severe mental illness. There was, I think the last count that we had was at least 80% of the individuals that we engaged for this program had severe mental illness. And that's one of the big reasons why they needed case management to try. We take for granted that we're able to sort of live, pay rent, do the things that we need to do to exist in society, but that's not a reality for many people who are chronically homeless. And so a few people were incarcerated, and then intellectual disability also made people not be able to succeed in their housing. But despite that, taking the people who died out, we still actually saw a cost savings. 21% cost reduction, and ED utilization and inpatient utilization plummeted for the individuals that are still alive, even if they weren't able to remain in the program. And I understand it's not fair to those who are incarcerated, but like overall we still saw a benefit. And because of this sort of data, we've been funded through 2023. I think is the last update that I got. So if we try and invest in our communities, we can actually impact health at a grander scale and actually decrease healthcare costs. And you need community partners to do it. We're not in the housing business. Hospitals are not in the housing business, right? But we can engage in those who are and sort of help them because we're all feeling it. Homelessness is hit by hospitals disproportionately. They have chronically homeless individuals are 4 to 5 times more likely to use healthcare services and repeatedly, and not necessarily for appropriate utilization. So there's a point for us to intervene. And this takes me to sort of what we're doing as an aggregate in Chicago. And this was an initiative from Ron Emanuel for the flexible housing pool. Basically, what the idea is that if we start investing as an aggregate with the amount of money that's in the Chicago and create a flexible housing pool, and invest in the communities to try and create more units, because like everywhere, right, there's not enough affordable housing. So what if we start putting our money where our mouth is and see if we can actually invest to benefit the community as a whole? The one thing I wanted to put this in the slide deck just because I find it amazing. The map of Chicago on the left is out of David Ansell's book. I don't know if you can see it, but one of the most amazing pieces of that map is that in terms of location, there's 2 communities that are beside each other where if you live in Washington Park, your life expectancy is 69 years old. And then Hyde Park, where Obama is from, and the University of Chicago is around there, it's 83, right? Like these are the stark sort of disparities that exist. And it's not acceptable. And so if we realize this and we have data to back it up, what can we do to sort of impact our community? I've been lucky enough to be a part of the advocacy that's gone into this, not very much of it, but it's been an eye-opening experience. But last week, or the 22nd, Cook County actually is also going to be a part of the housing business to try and provide permanent supportive housing support to individuals in the city of Chicago, to try and improve how we are able to stably house individuals. And overall, right, we're all trying to decrease healthcare costs, but we won't know until we try. So that's sort of where we're headed as a city, to try and really get our large hospitals to invest in housing, because that's been a huge amount of healthcare costs for a lot of our institutions. So this is where I'm going to end. This is I actually just took this and I was like, this is amazing in Vancouver. I think that we're at an amazing point, and those who are graduating, it's so exciting to be done. And also, there's an amazing amount of opportunity for you to engage in things like this if you're interested, but you won't know what you want to do until you experience it. So be engaged. Wherever you end up, say yes a lot. and sort of figure out what it is that what opportunities are available to the institutions that you go in. We all need to learn how to say no, but a good amount of what I've been able to experience has been just by saying yes and when wanting to see what it is that I could do in terms of a population health impact level in my practice of medicine. So, if you're interested at all, or if I can sort of help troubleshoot, this is, it takes a village. And I've benefited a great deal from the mentorship that I've received at my institution. But I'm happy to sort of help you figure out, if you're interested in social determinants and social medicine, how it can look like in your practice. And yeah, thank you so much for your time. I'll take questions. Thoughts, comments, concerns? Okay. Okay. All right. Thank you. I did this before. So, to give you a sense, I think Hayden's going to talk about how county breaks you and then makes you, is my first shift at the University of Illinois was, we are the town state of Illinois. No one realized that I was going into a single coverage shift as my first shift, a shift I didn't even know where the emergency department was. And so I showed up, and I got a phone call from the person who hired me going like, sorry. And so I showed up, and I was like, all right, it'll be fine. I figured the only thing I didn't know how to do was like figure out how to get into the emergency department, but I figured it out, got, resourceful. But the funniest thing was is that I had no issue. And that's not to say that I know everything. I still walk into shifts very much so with a heightened sense of being alarmed, of like not wanting to screw up, and I think that's important to still be scared. But it was easy. The hardest thing was not knowing how to write a note or admit a patient. I had no idea how to do any of that. But luckily I was with an IMEM who basically helped me out. But the biggest thing that was in my head was just do not be the dumb one. Do not be the dumb one, repeatedly, again and again and again. And it stayed with me. And just so you know, the residents that I work with now benefit from all of the teachings that are stuck in my brain from you. So thank you so much for the amount of education that you provided for all of us. I think I can speak for all of you in saying that. But it's a legacy, man. It's amazing. So thank you.